She is a member of life member of IDA, Indian Association of Diabetic Educator. She is a life member of Indian Association of Parental and Enteral Nutrition. She has several publications. Her area of interest is nutrition in critical care for renal and awareness on importance of nutrition in clinical setup. So I welcome you, ma'am, to our program, and please, I give over to you, ma'am. You can take over, ma'am.
Before I start with, I would like to thank Kaho also. Practice that is critical care nutrition. The flow would be like, what would be the needs and goals in critical care? What would be the evaluation of critical care in the last decade, which was bad for us, and current recommendations and practices in critical care nutrition and critical care nutrition in India and challenges. When it comes to burden of critical illness in India, overall burden, what we see is that is not only be precise to one organ of the body. It concludes with all body parts like cardiovascular disease, lung disease, cancer, liver disease, or GI diseases, and even the kidney disease. So what we have, this latest data, what I have got is July 2020, where around these 31,000 deaths have occurred due to the malnutrition or the critical care illness, which the malnutrition is been conquering in the ICU setups. When we talk about malnutrition in critical care unit, the metabolic stress, what that patients are having, increased caloric requirements, anorexic and decreased food intake are the main role players in causing malnutrition or the patient entering into an ICU with malnutrition. So what would be the ill effects, influences of it would be, there would be a prolonged length of stay in the ICU, mortality rate would be there, increased infection rate would be there, duration of mechanical ventilation would be more, and what leads to skeletal muscle mass wasting and weakness would be immobilization, prolonged mechanical ventilation support, profound inflammations. So these many were the reasons where we see why there is an increased mortality rate in ICU setups. And when it comes to nutritional issues in critical care units, malnutrition among hospitalized patients is a global issue for major importance. Prevalence of IPD malnutrition is as high as 50% among acutely hospitalized patients. So this is when the patient comes to you. It is not only in a critical care unit, it is also in the hospital where we see. That is why even with the NABH and what Dr. Priyanka has also said, okay, when we go into an assessment, as a patient comes to you, that is within 24 hours, we see more of malnutrition on admission itself. Least concerned about whether the patient is in ICU or in an acute hospitalization as an IPD patient. So when it comes to the nutritional issues, one, the stay in ICUs are more. There is frequent insufficient feeding or previously altered nutritional or metabolic status is there. There is an aggravated, condition is aggravated by prolonged underfeeding. And what would be the outcomes? The clinical outcome would be poor. There would be a prolonged stay in ICUs. High incidence of complications would be there and higher rate of mortality would be there. When it comes to bidirectional association between infection and malnutrition, when the patient is having decreased nutrient intake, malabsorption and increased catabolism, the chances of getting infection and malnutrition is more. So this infection and malnutrition, when they are being connected to each other, there would be impaired barrier protection and impaired immune functions. So this gets affected with the clinical outcome during the treatment or during the hospital stay also. What would be the critical care illness in ICU? So patients in ICU with acute disease, trauma or other major surgical procedures, there will be highly pronounced stress metabolism, which affects the nutrition, which has been specified to nutritional challenges with high risk of consequent malnutrition. When these many conditions are there in an ICU, what we get is that is high pro-inflammatory cytokine activity is there. Corticosteroids and catecholamines are released in higher amount. There is insulin resistant and other growth hormones are also been resistant. Secretions are resistant, sorry. Bed rest or no or reduced food intake leads to fast decline in body energy and nutrient store. What would be the need of nutrition in the present scenario? The state of critical illness that is associated with the catabolic stress state and systemic inflammatory response to the patients. What would be the complications of critical care illness would be infectious morbidity, multi-organ failure, prolonged hospitalization. What would be the outcomes of nutritional support? Maybe there would be an invert or a good metabolic response to stress, prevents the loss of lean body mass, reduce the length of hospital stay, and improves patients' outcome. So this is how we can work with the present scenario. And when it comes to goals in nutritional care, of course, we see the type of feeding, what we are supposed to, which can be seen in our next slides or the following slides. So when it comes to defining the goals in critical care in nutrition, the mode of transport of nutrition can be anything. Either it can be a parenteral nutrition or an enteral nutrition or an oral feeds, but the provision of calorie, proteins, and other nutrients should be sufficient enough. And the goal should be reducing the energy deficit, reducing the catabolism, avoiding avoiding malnutrition in well-nourished person and preventing deterioration in malnourished patients. So this should be the goal for us in a critical care unit. What would be the methods where we have a medical nutrition therapy in all IPD patients? What we can see today is that can be ONS, tube feeding, or a parenteral nutrition. So oral strategies are there, enteral strategies are there, and IV strategies are there. So these many are the food flows, like the type of diet, what we prefer giving to the patients, but how to do it, like how to start with this, and how we can decide, okay, this patient is supposed to be tube fed, this patient should be put on parenteral, this patient should be on PPN, etc. So when it comes to an evaluation in a critical care unit, in the past decade, we have seen that nutritional assessment was made mandatory whenever the patient enters into the hospital. And that is why the accreditation and the SOPs of a nutritional department in an hospital is been defined. So when we go with it, the risk of malnourished in ICU patient, complete nutritional assessment at least within 48 hours was the previous scenario, but current scenario is within 24 hours. That can be your Nutrix score or NRS score. We'll see the ill effects of the same. When it comes to Nutrix score, we have multiple things to do, like age, Apache 2, SOFA, comorbidities, days of hospital, from hospital to ICU, and IL-6 level. So what we have seen the drawback with the Nutrix score is not everyone is practicing with the IL-6 levels. Even in our hospital, what we practice in a critical care unit with Nutrix score is, we don't see the IL-6 levels every time the patient comes to us. The reason would be it is costlier for the patient to go for those tests, and is it actually needed? So this is the drawback with us who are practicing. Of course, the guidelines would be saying differently, the language what we use, and many countries would be having, without measuring the IL-6 levels, we would be measuring the nutritional status. There would be limited facilities in the lab. Of course, the cost of it maintains. So these would be the nutritional assessment drawbacks when we go with the Nutric assessment. Other tools which are being developed are NRS, MNA, GLIM, and SGA. When it comes to SGA, we prefer it more feasible, more easy, and more easy to record also, and to get the statements also. That is the final evaluation assessment of the patient. So that is more feasible in today's scenario. GLIM, of course, it is been practiced on a larger level, and the reliability is recently been approved. GLIM also gives a very good data. When it comes to MNA, there are multiple questions which are supposed to be fill in, but not all the questions are reliable in sense applicable. So when it comes to applicability with the questions of MNA, there would be few questions which is not related to the patients, on which condition the patient is admitted to that institute. So this is one drawback with that. And when it comes to NRS, it is not specific with the geriatric patients, but yes, they are more relevant to other sorry, I think it's going back. And when it comes to mode of treatment with the patients who enter into an ICU, how to provide the nutrients, one preference of there were two things which were been guided around. So one was with preference of a late enteral nutrition if it is being done. So early enteral nutrition within 48 hours of ICU admission is superior than late parenteral nutrition, late enteral nutrition. And when there is an uncontrolled hypotension or an vasopressor, then we used to hold enteral nutrition, or we can start with the trial dose. That we in our terms, we used to say it as a tropic feed or an isocaloric feed. Tropic feed itself. So when we give with the tropic feed or an hypocaloric feed with the lowest amount of doses, we can see whether the patient is tolerating well when the patient is on vasopressor or any other inotropes. Then preference of early enteral nutrition was supported by European Society of Intensive Care Units also. So in this case, what we have seen is early enteral nutrition over later enteral nutrition or parenteral nutrition was being preferred, and benefits of late parenteral nutrition would be lower mortality or infection rates. This can be due to the mode of administration of parenteral nutrition or MODS, like multi-organ has been damaged when priorly and parenteral nutrition is being advised, or the duration of parenteral nutrition which has been practiced in a certain institute is for a longer period of time without replacing it with a partial parenteral nutrition and on enteral nutrition, or sometimes it is with the parenteral nutrition only. So these many will be the drawbacks where we see the mortality and the infection rates and decrease in duration of mechanical ventilation or a time of a renal replacement therapy. I don't know how many of us in the panel we used to practice indirect calorimetry in our institute. We don't have it. Maybe an higher institute would be having that. But previously, we used to calculate the Harris-Benedict equation for calculating the energy requirement in an ICU setup, where then there were studies indicating it is not being specified, or it has been lagging, or it is in higher amount of energy which is being provided. So the indirect calorimetry is most preferred method of providing calorie or calculating the calorie requirements in an ICU setups. So what was there throughout the years, that early enteral nutrition was the first one to be introduced, and it didn't get any data regarding that. But after so many years, it was proven that early enteral nutrition is better than parenteral nutrition. Then when it comes to meta-analysis with the recent studies, there were not consistent, or a very results of early enteral nutrition were not consistent when a similar dose of enteral nutrition and parenteral nutrition was used. And what the present data is saying is early hypocaloric. This is what I have said with the tropic feeds also, starting with a minimal quantity. And then we can shift to other goals or the higher enteral nutrition, what we prefer. Then heterogeneity in the studies on the timing of a starting parenteral nutrition in the critical care unit. Then enteral nutrition versus parenteral nutrition, there was an SPN recommendation maximizing of effort to initiate enteral nutrition before starting with the parenteral nutrition. If enteral nutrition is contraindicated or intolerated, then within 3 to 7 days of ICU, we should start with the parenteral nutrition. And when it comes to gastric and post-pyrolic method of enteral nutrition, gastric feeding is of course strongly recommended, and we are following it in day-to-day. But when it comes to post-pyrolic, there are enough evidence are been defined where the risk of aspiration is more, or the feeding intolerance is there, though providing them with the prokinetic agents. And of course, intensivist may play a role in these recommendations. So when we come with the nutritional recommendation in an ICU setup, of course, calculating with the indirect calorimetry is the best. But we can go, or we can start with an hypocaloric nutrition with the initial phase, then we can make up with the isocaloric, and it depends on the occurrence where we don't see any effects like insulin resistant is there or hyperglycemia is there. So these many things can be followed once your patient responds well to the tropic feeds what you are giving, that is your hypocaloric, and then it can be isocaloric, and then with the maintained goal or the expected goal what we can go for your patients. So when it comes to macronutrients like calories, what we have seen just before slide, so we used to calculate or initially start with 15 to 20 kilocalories per kg idle body weight. And when it comes to protein, of course it is 1.2, but we have to see into any renal complications or hepatorenal complications where we are being look into the protein providers. But latest guidelines of SPN and ESPN are saying, okay, in a critical care unit, regarding with any of the renal conditions or any other hepatorenal involvement, minimum of 1 to 1.2 grams protein can be provided in an ICU setup in order to avoid muscle protein loss, and preferable proteolysis can be controlled. When it comes to essential fatty acids, it is the lipid level what we give into it. But when we start with that enteral nutrition, we prefer giving at least 30% of the total calories from the fat itself. And when it comes to parenteral nutrition, that should be an calculated and evaluated one, minimum of 1 to 1.5 grams per kg of the idle body. Per kg of idle body weight in 24 hours should be preferred through a parenteral nutrition. One study which was indicating glutamine is supportive in burns and trauma was being declared in the recent study, indicating even supplementation of glutamine is not effective in the burns patient even. So instead of putting a burden on the treatment cost, we can go with the regular nutritional supplements what we are supposed to give, and which is cost effective also. When it comes to micronutrients play an integral role in the treatment, but especially when it goes with vitamin C, it can be only provided when there are enough evidence of showing that the patient is deficient. Similarly, it is applicable to vitamin D also, because most of the patients, they lack with the exposure to sun during that ICU admission. Of course, this can be corrected with the exposure to sunlight. If the patient can be mobiled out of the ICU and put into an sunlight for a certain period of time, that can be effective. And if the patient is deficient, of course, we have to supply the patient with vitamin D. And when it comes to recommendations, the strength of recommendation, where we play like hemodynamically stable patients are there, then enteral nutrition can be started. If the patients are not stable, in such patients, we can at least start with the hypocaloric feed, anaerobic feeds, and that can be through continuous feeding also. Once the tolerance improves, that can be changed. So this is how we recommend in an ICU setup with the. This is again the recommendation.
Sorry to interrupt, Jigna madam. Sorry to interrupt. Could you please little rush up?
Yeah, sure, ma'am. As such, I'll be winding up. Only 3-4 slides are remaining.
Thank you. Thank you.
And this is the same as what we have discussed with the calorie and the protein requirements. And when we re-look into the practices, there is the same guidelines with the hemodynamic stability, whether the patient is, I guess everybody would be aware of all those things, but just to highlight few of the things, nutritional assessment in a critical care unit is must. And second thing is with the calorie and protein requirements, how much you would be providing. To start with can be 20 to 25 kilocalories, 1 to 1.2 grams minimum, even in a renal or a hepatorenal involvement patients. And of course, we have to see the mode of feeding the patient, whether it is enteral and parenteral or oral feedings at times. check the GRV volumes. If it is more than the feed what you are giving, that is more than 500 ml, then we may switch into skipping one feed in a day and then to restart with the tropic feeds. This is how we can see. And of course, GI involvements would be there, like diarrhea or vomiting or nauseatic. And sometimes the bloating would be there. Even bedridden patients may face constipation that may lead to bloating to such patients. So this is the approach what we can do in a critical care unit. I would like to just skip few of the things and go into the back thing. Recent studies are there where in closed nutritional supplementations with the closed feeding things, that is ready to hang fluids are available that can be provided to the patients. What is the recent thing what we have to be getting into the key points would be that whatever trials, as Dr. The previous speaker, I forgot her name, sorry. She also said that the RCTs should be done adequately and we should have a authenticity and a proper guidelines which can be followed by everyone and make it feasible. This is how we can go with the clinical trials. And when it comes to oral nutritional supplements, the formulas which are used in critical care units can have ill effects of their own, but it can be safely given in an ICU because it is what we are calculating. Like when it goes to blenderized feeds, it is not what we calculate. And the amount of contamination in that would be even higher into that. So this should be considered. And of course, all the guidelines are saying these many things should be given into the considered in an ICU. Thank you so much.